This conference will now be recorded.
Hello everyone and welcome to one of our mock discussion sessions, and today inshallah we are going to discuss diabetes in pregnancy. Of course I don't have to tell you how important diabetes is in your exam. They can ask you about everything: antenatal care, antepartum management, postnatal care, everything you can imagine can be asked. So every single word in the NICE guideline is important. This guideline in particular, I advise you to read it from the NICE guideline itself and make your own notes. Okay. Unfortunately, questions in the books does not cover every important point that can come in the exam. We are going to highlight some important points that came in the exam before and the expected points that can come in the exam too. So that's why I would like to start with some recall questions. For example, this one's from September 2022. I need you guys to open the mic if you have an answer. We have a primary gravida who has a family history of diabetes. She came to the antenatal clinic, or she came for you for any reason. How would you manage her? What you are going to uh, advise her to do? Are you going to advise her to do a self sugar monitoring, or to do a fasting blood sugar, or to offer a GTT now, fasting plus 2 hour plasma postprandial blood sugar, hemoglobin A1c? What do you think? I need you to open the mic, guys. I cannot see the chat box.
We cannot see the screen, doctor.
You do not see the screen?
Yes, no screen.
Okay, okay, thank you. Thank you for telling me this. Okay. Alhamdulillah, I'm able now to. Can you do it now?
Yes.
Okay, thank you. So, and
Yes,
now
okay.
I can also see the chat box, so you can use the chat box. So what do you think? This is from the last exam, by the way. Okay, Dr. Basma said fasting plasma, blood glucose, or fasting blood sugar. Anyone? Okay, let's elaborate something, guys, because this question is very common and you should not mistake it. When you have a question about diabetes, first of all, I should ask myself, am I dealing with a pre-existing diabetes, or I'm dealing with someone who is healthy but risky for GDM, or I'm dealing with a woman who had previous GDM? So I'm having three scenarios. Those are three scenarios, three conditions. Previous diabetes means diabetes 1 or diabetes 2. Previous GDM, someone who had GDM in her last pregnancy. Or I'm having a healthy woman now who is pregnant now, but she is risky for having GDM. This woman is a healthy one who is risky for GDM. Why? Because she has a risk factor. What is the risk factor? She is having a family history of diabetes. Okay? What the NICE guideline tell us about this woman? They told us, please do a GTT at booking or as soon as possible. And if it came out negative, repeat it again from 24 to 28 weeks. Okay? That's simple. That's simple. But the problem is, as Dr. Basma said, for example, she offered her a fasting plasma glucose. Fasting plasma glucose, Dr. Basma, is not our way to diagnose GDM. Not hemoglobin A1c, not fasting plasma glucose, not FPS plus 2-hour plasma glucose. All of those are not recommended by the NICE guideline to diagnose GDM in pregnancy. The only way to diagnose GDM is GTT, glucose tolerance test. When should we offer it? We offer it for high-risk patients at booking or as soon as possible when you see her. Okay? And if it came out negative, I would repeat it again in the second trimester between 24 to 28 weeks. If it came out positive, so this is a case of GDM, simply. Or maybe she is type 2 diabetes and she didn't know. Okay? If it came out positive, the GTT. So I should do what? I will manage her. I will give her medication. How we will manage a patient like this? What would you give her if the GTT came out positive? But by the way, before management,
Excuse me, Madam.
yes, yes, dear. You can write down. I didn't hear you. First of all, who can tell me the numbers? Who is positive for
Excuse me,
diagnosis?
Dr. Nada.
Yes.
I think, I'm not sure. He give in scenario he's symptomatic. Patient is symptomatic. I'm not sure, but I think
Like what symptomatic? Symptomatic for what?
complaining of dizziness, or dyspnea or something like this. I don't remember exactly.
How it will differ in your management? How this will differ in your management?
I am about thinking about she has type 2 diabetes.
Oh, she is already diabetic,
Yes,
but she does
yes,
not
yes.
know
And
it,
she is
right?
in early pregnancy, maybe in 10 or 11 weeks.
Okay, okay,
Mm.
even so, we
Uh,
don't have an established diagnosis for type 2 diabetes, right? There is no
yes.
well-known history for type 2 diabetes, right? So what should I
Why
do?
not?
What should I diagnose to
Why not
diagnose this
advise
patient?
her to self sugar monitoring?
Okay, I will tell you why. Because NICE guideline offers the self-sugar monitoring for a well-diagnosed and established diagnosis for previous diabetic patient. Previous diabetic patient. She knows she is diabetic. She's having her medications. Okay? Not someone who does not know she is diabetic or not. We can see it together. I think I open it here. We can see it together. Look, guys, because this is very important, and I saw many candidates have a conflict about this point. It's very obvious in the guideline, very, very obvious. First of all, basic knowledge. Do not use fasting plasma glucose, random blood glucose, hemoglobin A1c, glucose challenge test, or urine analysis for glucose to assess the risk of developing gestational diabetes. Okay? We do not offer those for assessing the risk. How we know the risk? From those points. PMI above 30, previous macrosomic baby, this woman is primary. Previous gestational diabetes, this woman is primary. Family history of diabetes, they said in the scenario there is a family history of diabetes. Or a sanity with high prevalence of diabetes, most probably the African Caribbeans. Okay, okay. Now I need to know what to do. What to do? I will use 75 gram to our oral glucose tolerance test for gestational diabetes in women with risk factors, the above one mentioned. However, for women who have had gestational diabetes in a previous pregnancy, I will offer the early self monitoring or the 75 GTT. Very obvious, very clear. Okay, for a woman with any of the other risk factors for gestational diabetes, I will offer what? The GTT at 24 to 28 weeks. Okay, guys? So if you are saying she is now in early pregnancy, for example, let's get back to uh, oh my god, you don't see my screen. Wallahi, I'm so sorry for this. Okay, I will share the entire screen so you can see what I was talking about here, guys. This is from the NICE guideline itself. Okay, my scenario now is this line. She is risky. Okay, she come in early pregnancy. Okay, I'm not sure whatever week. Okay, she had a risk factor, so I'm going to offer her GTT at 24 to 28 weeks. If the scenario came that she has a gestational diabetes before and she came to me now, I can offer her either early self-monitoring or GTT. Clear? Clear, guys? Hopefully, inshallah, it's clear now. Okay. No voice?
Repeat it, Dr. Nada, please.
Okay, we can repeat again. Because this point is crucial. This point is crucial. And I need you also tell me it's clear. When you have a woman in any scenario of diabetes, first of all, you need to know what kind of diabetes this woman is suffering from. Is she previous diabetic, type 1 or type 2? Does she have a previous GDM? Or she's healthy and risky for GDM? Okay? This woman, in the case we have here, she's a primary gravida. So there is no way she has GDM before. Is she type 1 or type 2? No, it's not mentioned. So what she's having a family history of diabetes. Okay? Okay. And now she came to me. What should I offer her? The best answer ever will be offer GTT at 24 to 28 weeks. If it's not there, offer GTT now. That's it. Simply. If she has a previous GDM, guys, having a risk for having type 2 diabetes by what percent? By the way, this is very important question. If a woman have a GDM in her previous pregnancy, what is her risk for developing type 2 diabetes?
Fifty percent.
50%. Yes, 50%. So there is a 50% risk that this woman will be type 2 diabetes. Maybe she know, maybe she doesn't. If she know, she will have treatment and she will tell me I'm type 2 diabetes and I'm on treatment now. Okay? If she doesn't and she told me just I'm having a history of GDM before, how I will deal with her, I will ask her to do a self-monitoring blood glucose test, okay, sugar monitoring, or do a GTT. And I doubt this will come in the exam because they have two options. And if it come in the exam, if so, I will go for self sugar monitoring because it's mentioned first in the guideline. Okay, hopefully it's clear now. Okay, this one, because this is a recall also. A primary gravida.
دكتورة ندى
Yes,
دكتورة ندى بليز البيشنت سيناريو not primary.
they told me
She's
she
second
was
pregnancy.
primary.
Yes, she is gravida too.
Whatever. Did they mention she was a
Whatever.
GDM?
Same. Okay.
They mentioned she is a GDM before?
No.
Okay. So I will deal with her as a normal patient. A normal healthy patient, just risky for GDM. Keep it simple for yourself, Dr. Sabah. Keep it simple. Don't assume things that is not written in the scenario. Okay, the other scenario is a primary gravida who is type 1 diabetic, a multi-gravida who is type 1 diabetic, suffering from proliferative retinopathy during pregnancy. She was anxious about mode of delivery. She has no obstetric complications so far. Okay, the first question I should ask you is proliferative retinopathy a contraindication for vaginal delivery? Yes or no? Diabetic retinopathy is a contraindication for vaginal
No.
delivery? Yes or no?
No.
No. No, guys. And it's mentioned clearly in the NICE guideline. Diabetic retinopathy is not a contraindication for vaginal delivery. Why I would choose CS in such scenario? Only if they mentioned an obstetric contraindication. If it's not mentioned, then I will go for normal vaginal delivery. Offer her normal vaginal delivery. Okay, this information is not mentioned in the guideline, but you should know. For just assurance, for just your own assurance, okay? When should you offer CS for a case of proliferative retinopathy? When she's having recurrent hemorrhage, not any case of proliferative retinopathy, a one who is having recurrent vitreous hemorrhage. This one most probably won't deal with the pushing and constriction during the normal vaginal delivery. It will be risky. So that's why we will offer her cesarean section. This is the only condition. But pre-proliferative or proliferative retinopathy is not a contraindication for vaginal delivery. Clear? Clear, inshallah. Okay, this one. A multipara type 2 diabetic patient. This is an exam question. Okay, very famous recall. Simple changes that will be in the scenario, but the idea is the same. She's type 2 diabetes, 36 weeks. Last ultrasound showed polyhydramnios and the baby weigh 3.8 kilogram. They are asking you how you are going to deliver her and when. This is when it's the best to see this flow chart. Let me share it with you. This is crucial for the exam. When and how you will deliver your patient. You can see the flow chart, right? Okay, I will maximize it for you. Again, I should ask myself, is she type 1, type 2 diabetes or GDM? Type 2 and type 1 diabetes will be delivered according whether she has complication or not. This woman, in the scenario, she's having a polyhydramnios, okay, and a macrosomic baby. So this is a fetal complication. So I should consider the delivery before 37 weeks. Now I know when. I should know how. Is there any contraindication in the scenario for normal vaginal delivery? Yes or no, guys? Polyhydramnios and baby 3.8 kilograms. Do you think this is a contraindication for normal vaginal delivery? Absolute contraindication? No. No, it's not. I should I will offer normal vaginal delivery. Unless there is an obstetric contraindication. Up to 4 to 4.5 kilogram, you can deliver this patient vaginally. Okay? Unless there is another contraindication. Okay, forget about your practice, please. Forget about your practice. You are going to answer the question according to the guideline. Okay? The guidelines say type 1 or type 2 diabetes, when it's complicated, you are going to consider elective birth. Elective birth means cesarean section or induction for normal vaginal delivery before 37 weeks. Now let's get back to our question. Our question say we have this patient. She is 36 weeks now. Okay? She's 36 weeks now. Who can give me the best answer within those choices? Open the mic, guys. I cannot see the chat box. A, B, C, D, E.
A.
The answer will be
B,
A.
A. You are going to offer her induction now? Okay.
Yes.
I think so too. I think so too. This is the best answer. Yes. You should induce labor before 37 weeks. So the best answer within those choices is offer her induction. Okay, guys? Don't go for CS unless there is obvious obstetric indication. Okay. Sorry. This one. It's a little bit tricky. It's not the same as the recall, not exactly the same. But because it's dealing with two guidelines, not only one, not only GDM, but it's dealing also with the small for gestational age. But same rules, same rules we will employ for any diabetic case. We have type 1 diabetes. She's 35 weeks. Okay. She's having regular contractions and she is 5 centimeter dilated. At her 20-week scan, they found that the estimated fetal weight is less than 10th percentile for the umbilical artery, and diastolic vein velocity is present. Now I would ask myself a question. She is type 1 diabetes, right? Okay, she's complicated, right? There is small for gestational age. So I should deliver her before, you can see this, before 37 weeks, right? Okay, she's now in labor. She's already in labor. She's now 35 weeks and she's already in labor. What should I do? Should I go for CAT1CS? Yes or no, please? According to the information given for you. No. If they just told me so, I won't go for Cat1CS. There is no indication for fetal hypoxia or acidosis or anything. Okay, guys? If they told you that there is obstetric indication, like, for example, there is placental abruption, or there is placenta previa, or there is vasa previa, anything that would make me go for Cat1CS, I will go for Cat1CS. But this is a complicated diabetic patient. I should offer induction of labor. She came in labor. She's already in labor. What should I do? I should admit her for continuous CTG. This is the best answer. Admit her for continuous CTG. Whenever the CTG is going to tell me that there is acute hypoxia, I will go for CS. If the CTG is telling me no, the baby is good, I will continue for normal vaginal delivery. She will deliver normally. Can you see my screen, guys? Can you see the guideline? Hello? I can see
Yes,
your hand.
yes, ma'am. We can see
Okay,
clearly.
thank you. Can you see here? Early admission
Oh,
is
yes, we can see.
recommended in women in spontaneous labor with SGA fetuses in order to instigate continuous fetal heart rate monitoring. Okay, this is rule. This is a rule you should know by heart. Whenever you have an SGA fetus, she came in labor, you are going to put her for continuous CTG. Okay? Okay, let's see our beautiful flow chart here to make you more secure about your answer. This woman have an estimated fetal weight below 10th percentile, okay? They told you that the umbilical artery Doppler and diastolic velocity is present. By the way, the diastolic velocity is the most important thing. If it's present, you should sigh, take a deep breath. I'm okay now. This baby is okay. He's not at risk. When you have an absent end diastolic velocity or reverse it, this is a very bad sign. This means that this fetus is hypoxic. This fetus is going to be acidotic. Okay? When I should deliver this baby? When the ductus venosus is reversed or absent. Ductus venosus, not absent umbilical vein velocity, not reversed umbilical vein velocity. Ductus venosus. Ductus venosus equal deliver now by any mean. If you can induce her, induce her. If she cannot be induced, go for cesarean section. I'm giving you general rules now. Are you following or lost? Following? Hello?
Yes,
Yes?
yes,
Okay,
yes,
thank you.
doctor. We are
So
all.
when I'm having a, I'm now repeating, small for gestational age baby, okay? And I have Doppler mentioned in the scenario. Which kind of Doppler? Which kind? Umbilical? Even if it's reversed, I'm not going to deliver her. I'm going to continue the monitoring. When should I deliver this baby? When ductus venosus is absent or reversed. Okay? Simple rule. Now again, when I'm having a diabetic patient and she's complicated by whatever, maternal or fetal complication, I know I should deliver her before 37 weeks, either by induction or by CS, according to her condition. Now I know that I should deliver her by 37 weeks, or my patient before 37 weeks. Okay? Okay, now let's get back to the scenario. because the choices, I made those choices by myself. She's now in labor. Should I stop this labor? Give her tocolysis or anything? No. If she's going in labor, okay, we can continue this labor. Should I give her corticosteroids and normal vaginal delivery? No. Corticosteroids is given for only CS cases, small for gestational age, that you are going to deliver by cesarean section. Those are the cases who will take corticosteroids. Cases who are going for normal vaginal delivery, there is no time to give her corticosteroids. Corticosteroids is given at least 24 hours before delivery. And she's in labor now. So there is no use for corticosteroids. I'm going through the choices. So CAT1CS, of course not. Tocolysis and corticosteroids, it doesn't make sense. Corticosteroid and normal vaginal delivery, no, they don't mix. Corticosteroids and CAT2 cesarean section, this is a silly option also, because this woman is in labor, guys. This woman is in labor. Okay, hopefully, inshallah, it's clear. Okay, now we are going for, yes.
In the scenario he mentioned in the index, velocity index above 90 percentile, 90 percentile.
Yeah, the scenario can be changed. If it's above 90, so it's large for gestational age. Now we are talking about another thing, not small. We are talking about large for gestational age.
No,
Right?
umbilical artery Doppler, index
Okay.
above 90 percentile.
How come?
I
There is
don't
no
know.
such
He
thing.
given a
There is no
scenario.
such thing like this. There is no such thing like this.
I'm
Umbilical artery
also
Doppler.
confused about. Yes, I'm sure it's remember. I'm sure I remember that mentioned scenario in some question in my exam.
Okay.
Synthesis like this. Synthesis like this.
I will
Index
write it
velocity
down. I
index.
will ask your colleagues about it. There is no such thing that is called umbilical artery Doppler above 90 percentile.
Yes. I am the first time I listen like that. Yeah.
It's strange.
Please ask my colleague if sure. Please
Yeah,
explain
I
to
will
me.
ask them. I
Okay.
will ask
Okay.
them. It's either they mentioned the pulsatile index or more than 2 standard deviation, less than 2 standard deviation, but there is no percentiles in the umbilical Doppler. Even it's so, it won't be above the 90. Maybe less than 9 percentile. I would accept it, but it even does not make sense. Anyway, I don't know what it means, honestly. If it's above the 90th percentile, I don't know what this means. If they mean it's normal, maybe. Maybe it was something else, but you mistaken saying it. Means it's normal. Umbilical artery Doppler is normal. Okay, it's good. I will go for normal vaginal delivery. Good. I will monitor her. By the way, sometimes they will ask you how often you will do Doppler assessment for this baby if he's having a normal umbilical artery Doppler. How often? A very, very famous recall. Every 2 weeks, once per month,
Hi.
every 2 days. What do you think? You can cheat. When it's normal, guys, we are going to do it fortnightly, every 2 weeks. Every 2 weeks. Okay? When there is pulsatility index more than 2 standard deviation, I will do it twice weekly. When there is absent or reversed in diastolic volume, I will do it daily. The Doppler, I'm talking about the Doppler. I will do the Doppler daily. You know why daily? Guess why? Why in this condition I will do daily Doppler? Because I'm waiting for the moment the ductus venosus will become reversed or absent, I will deliver this baby. And the guideline told you, do not depend on the CTG for such case. Do not depend on continuous CTG. CTG is not your method for timing of delivery. And I'm repeating myself over and over, and I wish you remember my words in the exam. Please choose the timing of delivery depending on ductus venosus, not the CTG, not umbilical artery, not uterine artery, not the middle cerebral vein, middle cerebral artery, sorry. Okay, the ductus venosus. That's why when we have absent or reversed ductus venosus, endosteric velocity, I will do daily umbilical artery Doppler and ductus venosus Doppler. Why? Because once ductus venosus become reversed or absent, I will deliver this baby. Inshallah, you will remember. Inshallah. Okay, some book questions and some old recalled questions. Those are old recalled questions, and I think they are easy. Inshallah, they are easy. What is the strongest predictive factor for gestational diabetes? I need you to be quick, guys, please. Okay, I will try to see the chat box.
B.
Okay, I now can see your answers. Yes, it is previous gestational diabetes. Yes, excellent. Okay, the second one. The talk article about this topic. It's about bariatric surgeries and how it will affect the measurement of blood glucose. They said simply, and this is the most important point in the whole talk article, that the patient who had a bariatric surgery before, 1 hour postprandial test is not going to be accurate for detecting her blood sugar. Why? Because of something called late dumping or postprandial hyperinsulinemic hypoglycemia. They have a hypoglycemia 1 hour postprandial. So whenever she's going to have a 1 hour postprandial blood glucose, it will be low. So this is the only test that you cannot use for detecting diabetes in this woman or for sugar monitoring. Okay, simply this is the idea. Okay, the third one. This one, guys. I know it's an obstetric case, but I want to highlight something about it. A multi-parous diabetic patient. She has been 3 hours in the second stage. The baby station is +1 and she's fully dilated. What question should I ask myself to answer this scenario? is she having a delayed second stage or not? Yes, of course, she's having a delayed station. Okay, excellent. Yes, yes, inshallah. You cannot hear me clearly. I'm sorry for this. So I'm having a station +1. Okay, she's fully dilated. Okay, and she's delayed. Of course, I'm not going to wait for another hour. And of course, I'm not going to advise her to push. And they didn't mention anything to make me go for CS. Okay, I'm thinking with you. If I was in the exam, I would think like this. Okay, no fetal hypoxia. So why I would go for CS? Okay. Now the vacuum. The baby station is +1, guys. You should use the vacuum 1 when you have +2 or more. And you should expect that a diabetic patient, and she is a multiparous, okay, and she has a delayed second stage of labor, that this baby is large or macrosomic. So the best is forceps in the obstetric theater. This is a recall. I'm not sure if there was another details about it in the exam. I'm not sure. Okay, but the best answer, in my opinion, is forceps in the uh, in the OT. Okay, even by exclusion. Yeah. Okay, the next one is really silly question, and I don't know why it come in the exam over and over and over. This one is good. Screening for GDM in current pregnancy for previous GDM. When should it be? I think we have just said this piece of information. Please answer it right, without even looking in the options. Yes, thank you. Thank you so much. At booking, and if negative, I will repeat it at 24 to 28 weeks. Okay, then who I will offer GTT at 24 to 28 weeks? Who? Who, guy? Excellent. Any patient who have risk factors, high risky patients. Yes, excellent. Okay, a woman with CF, cystic fibrosis. She came preconceptionally to ask about her risks in pregnancy. What she's risky for? Yes, she's risky for GDM. Excellent. I want to zoom in. This is better. Okay. What is the side effect of olanzapine in case of diabetes mellitus? This is an antipsychotic. Hyperglycemia and ketoacidosis. Excellent. Of course, hypoglycemia and ketoacidosis is something silly, but please take care, because sometime in the exam we have like eye confusion. You know the answer and you are very enthusiastic to select an answer because you know it. You feel that the question is easy, and yes, I know the answer, and you will go for A. So please take your time and read each option uh, easily, slowly, because you may choose A by mistake. Okay? The other one, she has schizophrenia and on olanzapine. She's asking how the drug can affect her pregnancy. I think this is a very silly question also. We have just said that this woman is risky for hyperglycemia, so she's risky for gestational diabetes. Okay. A pregnant woman who developed GTM in her current pregnancy wants to know how she would be followed up after delivery. This is also a very common recall. How would you follow up your patients? Excellent, everyone. Fasting blood glucose or fasting blood sugar after 6 weeks, then yearly hemoglobin A1c. Excellent. Okay, this one is good to revise how you are going to manage your patient antenatally. A pregnant woman with type 1 diabetes came for antenatal care in the first trimester. She's well controlled and she's asking about insulin requirements in pregnancy. Which one you will choose? I need to hear your answers and I will tell you why this question may conflicts between candidates. Why you are so afraid, guys? You can say it's okay. Okay, I'm having C and I'm having A, another A. Okay, excellent. I will tell you why I choose this question. Okay, Dr. SH, there is no way I will increase intermediate acting insulin because we don't use intermediate acting insulin in pregnancy for the first instance. Okay, the NICE guidelines say that the best insulin to be used during pregnancy is rapid acting insulin, right? Okay. But when you have a patient who is well controlled on whatever she is taking prior to pregnancy, keep her on her management, keep her on her drugs. Okay, this is the rule. You are having now a type 1 diabetes. She was having whatever type of insulin and she's well controlled. So nothing will be changed from preconceptional period. But if I'm having a choice, if I'm going to offer her something, for example, if she's now type 2 diabetes, okay, and she was on let's say what metformin is okay to be continued during pregnancy, let's say some of agents or whatever agent, and you are going to offer her according to to her measurements, of course. She is going to keep on metformin. But if metformin is not controlling her, what would you offer her? Rapid acting insulin. Okay? Is it clear? So what drugs we would stop when she become pregnant, guys? Diabetic patients always, yeah, yes, almost always, they are going to be having statins in their managements because they are having high lipids and the high cholesterol. Almost every diabetic patient I have seen is having high cholesterol or LDL, and she is on statins. So I'm going to stop the statins. If she's taking metformin, she can continue metformin. If she's on insulin, of course, she can continue the insulin. Okay? And we are going to offer her folic acid. What is the dose of folic acid for diabetic patients? 5 milligram, yes. And the answer for this question is C. C. Nothing will change from preconceptional period. If she is well controlled, then keep her on her management. So when should I choose go for rapid insulin, or there is no way we are going to increase or decrease rapid insulin? It's not my job, by the way. It's not our job. It's not our job. This patient is going to be managed by obstetric clinic and diabetes clinic and her GP. Okay? Both of the three clinics are going to manage this patient, and it's not my job to decide whether I'm going to increase or decrease the dose of insulin. Okay? This is a very simple question. Very simple. This is a silly question. I think so. But because NICE guideline mentioned the word rapid insulin, all candidates will go for rapid insulin. No, they're just telling you that the best agent to be used during pregnancy is rapid acting insulin. Why? Because it's easily controlled. And the fluctuations of blood glucose during pregnancy is different from preconceptional period. This woman can have rapid hyperglycemia because she had a meal containing fruits, or she was craving for cakes, for example, and she can have a severe hypoglycemia because just she walked through the street because of the high metabolism during pregnancy. That's why rapid acting insulin is the best for her. Why? Because it's easily manageable. Whenever she's having high blood glucose, she will take a shot. If she's having a low sugar, I will give her something sugary or glucagon. It's coming on. Okay? It's clear now, guys? Okay. Sorry. Falling insulin requirements in women with pre-existing diabetes is a marker of placental dysfunction and associated with increased risk of preeclampsia and small for gestational age fetuses, and so on. Young lady with diabetes presented in emergency department with blood glucose less than 4, altered consciousness. What is the drug of choice? When you have a severe hypoglycemia or acute hypoglycemia, what should you do? This is basic knowledge, by the way. It has nothing to do with diabetes or NICE guideline or anything, even it's not mentioned. No, for acute hypoglycemia, Dr. Ayatul, we are going to give glucagon 1 gram IM. This is the best agent for the treatment of acute hypoglycemia. Okay? This is the life-saving shot. A life-saving shot. Then if you are going to admit her, you are going to control her with what? With intravenous dextrose plus insulin, not dextrose alone. 5% dextrose plus insulin. Okay? Never ever give a diabetic patient dextrose alone. So glucagon 1 gram IM is a life-saving shot. Okay. In insulin-dependent diabetes, what is the acceptable fasting blood glucose range in pregnancy? Very common recall question. And the numbers are very conflicting. I'm not sure those are the correct number, but those numbers were mentioned in the recall file. Okay, general rule: any insulin-dependent diabetic patient, her blood sugar should not go below 4. Okay, so I'm having 4 as the lowest limit. Okay, so the best option here is C. I'm not sure 7 is mentioned or not, but this is the best option we have. And I think it's a very good chance to revise some numbers. Where is it? No, not this one. I will reshare my screen. Let's revise some numbers. Okay. You can see my screen now.
Yes, I can, ma'am.
Okay, thank you. So when I'm having a diabetic patient in pregnancy, we have some numbers to memorize. Okay, this is Bible for us. For a diabetic patient before pregnancy, I should have a fasting plasma glucose 5 to 7. Okay, and 4 to 7 before meals. So 4 to 7 is acceptable if it comes in the options. 4 to 7 is acceptable. Okay. Of course, any patient 10%, you should you should advise her not to get pregnant. What is our aim? Our aim is to keep it below 6.5. All of this number can come in the exam, and it already came in the exam before. We should keep it below 6.5. Okay, guys? I'm having now a diabetic patient. How I will monitor her during pregnancy? We will monitor her by what? By hemoglobin A1c as a start. Why so? Because hemoglobin A1c gives me an idea about the last 3 months control. Okay, so if it's 6.5 or less, this is excellent. This means that this baby has a low risk for congenital anomalies. If it's more than 6.5, this baby is risky for congenital anomalies. So I should keep an eye on him. In any ways, I will offer this patient an ultrasound at 20 weeks like any other one, but I'm going to add a cardiography. Okay, detailed cardiac anomaly scan. Not every patient I will do detailed anomaly scan for the heart. Only specific patients. Like, for example, sickle cell anemia. This kind of patients need a detailed anomaly scan at 20 weeks. Diabetic patient, she is going to need a detailed anomaly scan for the cardiac chambers. Okay, so make sure in the AMQ choices, if they ask you about the kind of ultrasound you are going to do at 20 weeks, make sure that it's the normal congenital anomaly scan at 20 weeks plus cardiography or detailed cardiac anomaly scan. Make sure that this one is present in the options or not. Okay, guys? Do we offer or routinely measure hemoglobin A1c in the second, third trimester? No. It is beneficial in the first trimester because it gives me idea about the last 3 months or about the control. Okay? And if someone risky, like the patient who we had before, she's risky, okay? And I'm going to do a GTT to know if she's having a GDM or not. But they told me in the scenario that she might have a type 2 diabetes, or she was diagnosed by type 2 diabetes and she is not taking her medication. I'm going to order hemoglobin 1c. Okay, again, I'm having a pre-existing diabetes, type 1 or type 2. When I see this patient, I'm going to order hemoglobin 1c. Okay, to determine whether she is having a low risk for congenital anomalies or not. This is one. Okay, number two, if I'm having a patient with type 2 diabetes and she's not taking her medication, poor compliance, or they told me that I might have a type 2 diabetes, but I didn't go through it. I didn't go to my GP appointment. I will order hemoglobin A1c to detect whether she's having a type 2 diabetes or not. Okay? Okay. What else should I order hemoglobin 1c for? I don't think we have another scenarios. It's either previous diagnosed diabetic patient or pre-existing type 2 diabetes who is not compliant to medication, or she is not sure they told her she's type 2 or not. Um if she's just risky, having a risk factors from the risk factors mentioned in the guideline, no, we are going to order GTT. That's why every word in the scenario matters. Every word. Okay. Those who are taking insulin, they should maintain their capillary plasma glucose above 4. Below 4 means a catastrophe. A catastrophe is going to happen. What are the numbers of GTT to diagnose GDM? 5, 6, 7, 8. 5.6, 7.8. Okay? Any woman who is insulin dependent should have either a sugary tablet, bonbon, whatever, tiny chocolate or anything in her bag or glucagon tablets. Okay, so that's why I'm telling you every word matters, wallahi. And that's why the recalls are very hard. uh, okay, this one is really good also. 27 years old lady had a renal transplantation 2 years ago. Now she's pregnant and on some immunosuppressants. Which immunosuppressant will not cause gestational diabetes? Very famous recall. Yes, azathioprine. Excellent. Okay. Uh, okay, this one is about hypoglycemia. Okay, we have a diabetic woman who have an instrumental delivery 2 hours previously. Antenatally, she complained of severe lethargy, but she's found to have normal hemoglobin. So they are telling you she's not anemic. She's confused, bradycardic. Temperature is 35. Heart rate is 45. Oxygen saturation is 80%. Blood glucose is 4 millimole. She's hyponatremic and she's having a decreased reflexes. What will the patient need following initial supportive treatment? This one is really good. Yes, excellent, Dr. Osei. This woman, guys, the key answer for this scenario is this. She complained of severe lethargy antenatally. And they just thought about anemia, but she's not anemic. She's now having a severe hypoglycemia. Okay? And she's having low blood pressure, low heart rate, severe bradycardia. She's 45. And the temperature, severe hypothermia. This is not just hypoglycemia. This is not just hypoglycemic coma. If you are thinking about hypoglycemic coma, this is not a hypoglycemic coma. This is something else. This goes with myxedemic coma. She was having a hypothyroidism and no one get it during the antenatal care. And when she had the stress of labor, she developed myxedemic coma. So the only shot that will save her life is what? IV levothyroxine. Excellent. Okay. So when you get the right diagnosis, you are going to get the right answer. Diabetic ketoacidosis is a very important talk article. Okay, they can ask you about the numbers or the management, and both of them is really easy. It's not difficult. When you have a type 1 diabetes, okay, and they are more prone to develop diabetic ketoacidosis, of course, more common. I'm not going to lie to say they are almost all cases of diabetic ketoacidosis are type 1 diabetes. I have never seen a type 2 diabetes who have a diabetic ketoacidosis. Okay, and it has something to do with the physiology and pathophysiology of diabetes, but whatsoever, even it's happened. a type 1 diabetes with diabetic ketoacidosis. She's having a serum bicarb 13, a serum glucose 18. What would be the threshold value for serum ketones to confirm the diagnosis of DKA? Very important question. And take care, there among the options there is nanomole and there is millimole. So it's 3 millimole. Yes, excellent. 3 millimole. We have, guys, some criteria to diagnose DKA. First, the ketone level above 3 millimole, or the urine ketone level +2, or a plus blood glucose more than 11 millimole per liter, or known diabetes mellitus. So either you know that she is diabetic, or you measure the blood glucose and it's above 11. Okay? Plus bicarb less than 15, or pH less than 7.3. Anything that say that this woman is having acidosis, metabolic acidosis, of course. Okay, so I need something to tell me that she is acidotic, bicarb less than 15 or pH less than 7.3, a ketone level in blood more than 3 millimole, in urine +2, and a history of being diabetic or the blood glucose more than 11. The criteria can come in the exam. Yes, they can bring it in the exam. Why not? Okay, now when you have a woman with DKA and she's pregnant and they're asking you about the initial fluid replacement, this is also a very important question. What do you think? I'm having D, E. Actually, it's E. It's E. 0.9% saline. Sorry. Okay, the isotonic saline, or 0.9% saline, is the best for those patients because they are having negative fluid balance. The only thing that will give this fluid balance again, equality, is the 0.9% saline. Hartmann solution, I'm not sure who chose Hartmann solution. We use it for cases of hemorrhage, for example, but not according to the RCOG. Okay, it's not the first line. I'm telling you about the practice in many facilities, but not according to the RCOG. Hartmann solution can be used for resuscitation, for example. Yes, it's the best, by the way. Hartmann or lactate, Ringer lactate. The best solutions for emergency situation, for resuscitation. Ringer lactate or Hartmann solution. But here in DKA, the initial fluid replacement is 0.9 saline. Okay, this one. Some numbers, who can remember? This woman had gestational diabetes. She gave birth to infant weighing 4.2. She is now reviewing at 6 weeks postnatal. She has had a blood test and the results indicate that she will need further testing to see if she has a type 2 diabetes. So what do you expect the result was? She needs a further testing for type 2 diabetes. What we do for follow-up, guys? You may be shocked with the question, but it's really easy. Yes, fasting plasma glucose. Right? So simply, I'm going to overlook all those options. I'm going for fasting plasma glucose more than 6 millimole per liter. Okay, a primary gravida who is type 1 diabetic is admitted in labor at 37 plus 2. Is this normal? Can we admit her in labor 37 plus 2 weeks? Take care, I'm trying to trick you. Can anyone remember the timing of delivery in uncomplicated cases of previous diabetes? Yes, thank you. 37 to 38 plus 6. So, if she's not complicated, yes, why not? Thank you, Dr. Osei. Guys, those numbers are crucial for the exam. The timing of delivery is crucial for the exam. Timing of delivery will depend on whether the case is complicated or not, whether for pre-existing diabetes or gestational diabetes. You should ask yourself, is the case complicated or not complicated? Don't think about vaginal and cesarean section. Think first about the timing. Then see if there is an indication for cesarean section. If there is not, go normally for normal vaginal delivery. This woman could have normal vaginal delivery. She can have instrumental delivery. She can have induction. She can have everything. So what is the values that you should keep during labor? Yes, 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 yes. Excellent, everyone. It's 4 and 7. Yes, exactly like uh, the fasting value, the postprandial values during pregnancy. 4 to 7. Okay, this one. We are about to finish. Yes, the pre-meal. Thank you. We have a well-controlled type 1 diabetes. This is very important. Admitted for induction at 38 weeks for her second pregnancy, having had a previous normal birth at 36 weeks. After vaginal examination, she's 6 centimeters dilated. Her blood sugar drops to 3.5. No symptoms of hypoglycemia. How you will manage her? If you don't know the answer of this, I will cry. Yes, excellent. This is when we commence intravenous dextrose and insulin infusion. Can anybody tell me why? Why I didn't give her intramuscular glucagon? Yes, she's in active labor, but this is not why. Because she's not symptomatic. She's alert. Yes, excellent. She's alert and conscious, and there is no symptoms of hyperglycemia. So she will be managed by intravenous dextrose plus insulin. I told you, never, ever, ever, ever choose intravenous dextrose alone. Yes, this is because the stress of labor. Excellent, Dr. Uzay. Dr. Uzay is saying this hypoglycemia because of the stress of labor. Yes, excellent. Whenever you cannot maintain the blood sugar during labor between 4 and 7, you can commence the intravenous dextrose and insulin infusion. When you have a patient unconscious, uh, she's not responding, she's having a sort of coma, a life-saving shot is intramuscular glucagon. Okay, so the symptoms are very important. Last question, guys. She is having metformin, okay, and from 32 weeks, isofan insulin was added twice daily in addition to metformin to achieve glycemic control. The woman is planning to breastfeed. What advice should be given with regarding to hypoglycemic agent in the postnatal period? This is very lovely question. I want to see what you are going to choose, and I will tell you a general rule about postnatal management. Okay, I will give you a hint. I will give you a hint. In the postnatal period, especially if the woman is breastfeeding, she is going to burn more calories. Okay, she's going to have high metabolism and she's going to burn more calories. So I have a fear that she will develop hypoglycemia easily. So do you think insulin is a good choice for this woman? Insulin is not a good choice for this woman. For a breastfeeding woman, insulin is not a good choice because she will develop severe hypoglycemia. Okay? So I can stop the insulin and continue with the metformin with monitoring, of course. Okay, why? Because she's type 2 diabetes. She only needed the insulin during pregnancy for good control. Now after delivery I don't need the insulin, especially that she is breastfeeding. Okay, what about a GDM patient? A GDM patient who is was taking metformin, okay, and she was well controlled. Should I stop the metformin or continue the metformin after delivery? Excellent. Gestational diabetes means that this woman is diabetic because of pregnancy. If she's not pregnant anymore, she does not need the medications anymore. So we are going to stop the metformin, or even if she was taking insulin even if she is not well controlled with metformin alone and she needed insulin, all medications will be stopped after pregnancy, and we are going to monitor her after 6 weeks to make sure she is not diabetic. Thank you so much, guys. You have been amazing today. Wallahi, mashallah. Very cooperative. Unfortunately, we didn't take hypertension, but it's okay. I'm going to reschedule another appointment, inshallah. We are going to revise hypertension. Hypertension is not difficult at all, at all. If you just forget about the old guideline and don't answer old question about hypertension, it will confuse you like hell. Okay, inshallah, maybe next Sunday, I'm going to confirm with you hypertension, and maybe we will take another topic with it. Thank you so much for attending today. See you soon, inshallah. Anyone have any question? Yes? Okay. See you soon, guys.
Thank you.
Welcome, dear.
Live session. Thank
Thank
you.
you, ma'am.
My pleasure. My pleasure. Thank you so much.